Hi, everyone. Welcome to the John Hope Franklin Center. My name is Catherine Inks. I'm the coordinator of this lecture series, as well as the multimedia communicator for the John Hope Franklin Center. I'd like to welcome you today and thank you for braving this kind of cold and drizzly weather, which is no one's friend. I have a couple of short administrative announcements. If you parked in any of the area parking decks, either over here off of Irwin or off of Flowers, we do have 1 hour's worth of free parking. You can pick a voucher up from me after today's event. Also, I have a sign-in sheet. If you could sign in today and let us know you attended our event, we like to keep track of those numbers. And if you want to opt into our once-a-month newsletter, you can share your email address with me here. You'll get updates about upcoming courses, events, funding opportunities for students and faculty, all sorts of great things. So I'm going to start that here. And help me get it all the way around the room today. I'd appreciate it. Lastly, we are recording today's event, so if you had someone who couldn't make it out today, in about a week and a half, we'll have it up on YouTube for them, at least a clip of it, and they can contact me if they want to see the whole thing. So with that, I'm going to turn things over to Dr. Charles Pio, who will introduce our speaker today. Dr. Pio is one of the directors of the Africa Initiative who is sponsoring today's event.
Thanks everyone for coming out, and the Africa Initiative is really pleased to be able to be a sponsor for the event today. Michael Haglund is Professor of Neurosurgery, Neurobiology, and Global Health, and Chief of the Division of Global Neurosurgery and Neuroscience. Since 2007, he has partnered with Makerere University and Mulago Hospital in Kampala, Uganda, to develop neurosurgical care in country. He has transported millions of dollars worth of equipment, trained neurosurgeons, and transformed neurosurgical care in Uganda. Recently, he has established a center for epilepsy and epilepsy care in Kampala. His efforts are expanding into neighboring countries in East Africa to extend the impact of his work. He is a past winner of the VELGI Global Health Education Faculty Award from the Consortium of Universities in Global Health, the Humanitarian Award from the American Association of Neurological Surgeons, and the Alumni Humanitarian Award from the University of Washington School of Medicine. We're truly fortunate to have Mike Hagglund with us today to tell us more about his important work.
Thanks. Appreciate that. It's nice to be here. I guess what I'd like to do today is just take you through kind of the story. But what it shows is someone who is completely naive and doesn't have any idea what he's doing can actually, over a period of time, if you're kind of the Angela Duckworth, passionate about it and have the perseverance, you can actually accomplish some things. So I have some disclosures just in the sense we get grant funding from several companies to help us with our work in Africa. So if you do you have a way to turn down the lights just a little bit? I don't know if you can get that or not. I don't know. That's good. That's perfect. That's plenty. So if you look at the world population and you look at the U.S. set to 1, obviously places like India and China are much bigger. But if you look at Sub-Saharan Africa, and then you take and you look at the physicians and you focus in here on Sub-Saharan Africa, that falls off pretty much into the Atlantic and Indian Ocean. There's not many physicians in Sub-Saharan Africa. This becomes even more acute when you look at something like as complex as neurosurgery. There's 3,600 surgeons in the U.S., and when we started in 2007, there was only 565 surgeons in all of Africa. Well, that doesn't sound very good, but it gets even worse when you look at Africa and dividing it up into northern Africa, places like Egypt, Morocco, Tunisia, and South Africa, and compare that to East Africa. It turns out of those 563 neurosurgeons, 486 were in the northern part of Africa or South Africa, leaving about less than 80 neurosurgeons for all of Sub-Saharan Africa. So if you take two countries, one Morocco and one Uganda in 2007, had a similar population, but the number of neurosurgeons in Morocco was 171, which is one neurosurgeon for every 187,000 people. Now in the US, it's 1 to 88,000, so that's at least in the range. But in Uganda, it was 1 to 6 million. There was only 5 neurosurgeons in the whole country, 4 located in the capital city of Mulago, and 1 at a cure hospital, pediatric cure hospital that Ben Wharf, who's now at Boston Children's, started on his own. He went over there bravely in the middle of an empty field, set up a neurosurgery pediatric hospital. all of East Africa pretty tough in the sense of one neurosurgeon for 10 million. Some countries in East Africa, Burundi, other countries like that, don't even have a neurosurgeon. So, that being said, I was minding my own business, doing work in Ecuador, doing just general medical work with a friend of mine, Tim Driscoll here, through our church. And then all of a sudden at my church in Raleigh, Pastor Jackson Sinyanga showed up. He had a little church of 50,000 people. The only place they could meet together as a group was in the National Soccer Stadium. And he came to my church and he was going to speak on prayer, and he looked at me and he said, Dr. Haglund, you're going to go to Uganda and do great things for God. And I said, well, that's fine, but wrong continent, not even the right place. He says, no, this is a word from you, for the Lord, for you. You're going to go to Uganda and do great things. So that's when I started looking things up and started finding all this data, and I was horrified. And at his invitation, we went to Kampala, Uganda. This is from the 4th floor of the hospital looking across at Makerere University, which is one of the best universities in East Africa. This is the slums that get set up in the little ravine between the two, and when it rains, then dysentery and cholera break out, and then they all come up to the hospital. This was the hospital that we saw, the National Hospital. It's Mulago Hospital. I don't know if somebody stole the G or it just fell off, but this 1,500-bed hospital was a state-of-the-art hospital in 1962 when Uganda got their independence from Great Britain, from the United Kingdom. And as a gift to them, they gave them this beautiful brand new 1,500-bed hospital. Well, 40 years later, Idi Amin, a lot of war-torn, a lot of corruption, a lot of poverty, it's really broken down. And this is what their ICU looked like. It had beds, no monitors, no equipment to take care of patients. In fact, I found this kind of horrifying. As you rolled through into the open doors of the ICU, up above it, the sign said no man's land. Sort of like you went in here, you probably aren't coming out kind of thing. This was the recovery room, had 4 beds, one little thing to get oxygen, and that was it. This was the operating room, which was most horrifying. There was a bed. This is not an anesthesia machine. This is a vaporizer. You have to handbag the patient to give them oxygen through the whole case. Now, the funny thing, well, some of the rooms in Mulago still used ether. And, like the canary in the mine shaft, when it dies, the miners know it's time to get out, something bad's happening. When the shortest nurse faints from the ether fumes building up, it's time to shut off the Bovie cautery so you don't get an explosion. That's what they were doing. And when I took this photo, some nurse asked me from Mulago, said, what are you doing? I'm saying, well, I'm taking a picture that you guys don't have any equipment, and it's a problem. She goes, we do have equipment. She ran in with this and put it on there, and I snapped my photo, and I got on the plane. I was coming home. When I got on the plane coming home, I noticed this is a defibrillator, but it's only got like 1 paddle, so it really isn't going to do much for anybody that's having a heart attack because it's only got 1 paddle. And this gentleman was kind of the prophetic picture of what happens. This gentleman had they have bodas over there. Those who've been to Africa, they drive crazy. A lot of them don't wear helmets. They zoom in and out of traffic, and very frequently they fall off their motorcycle and hit their head, and they get blood clots in the brain. This gentleman had a subdural hematoma. And the reason I took this picture was A, he was a neurosurgery patient, and B, he was on the only ventilator in the whole hospital. They had 1 ventilator for 1,500 beds. And if I'm on the ventilator and some young healthy person like you comes in and they say to Professor Haglund's family, sorry, we have a young healthy person. If your family wants to handbag you for a while till they get tired, we can, but we're going to put the younger, healthier patient on the ventilator. Well, they used in that time, it's called a Hudson brace and bit. Basically, it's like the old woods, screwdriver, like drill you used in the wood shop that goes around in circles. That's how they got into the skull. And then they used a braided wire, kind of like they used on Luca Brasi and The Godfather, to take him out, to cut through the bone. And then they didn't even have things to stop the bleeding on the brain. They would just put gauze on the brain and wait a few minutes and then peel it off and see if the bleeding stopped. But this guy had actually survived. So I took this photo, and I come back the next morning when we're doing some more rounding, and he's gone. And those of you who've been to Africa, if somebody in Uganda or East Africa says we've had a little hiccup, to me a hiccup here is, the air conditioning went out for 5 minutes, or, it rained today and my car I just washed got dirty. It's not, hiccup in Uganda is like usually a bigger thing. Well, their hiccup was the power went out in the middle of the night, generators kicked right back on, but the nurses for 20 minutes didn't notice that the ventilator reset to 0 and pupils were fixed and dilated, and he was dead just because of and he has no monitoring equipment here to see what's going on. So, this shows you how naive I was. So I get on the plane. This is my list from my notebook of what we need. Okay, we need a headlight. We need a drill. We need a bovie. We need a bipolar. I don't know how many O2 sat monitors. We need some ventilators. We need some things. And then my favorite part of being naive is I need 2 long extension power strips to hook everything up. That was my idea of what we were going to do. So from there, we did a little better. So what was the problems in 2007? There's really 4 main ones. 1 neurosurgeon for 6.6 million people, no technology, no operating room, and no training program. On that slide I showed you, Morocco has 5 training programs to train more neurosurgeons. Uganda had none. So came up with a solution I called the 4 T's. So the first T is technology. So when I came back, this is when Dr. Mercer first started in the Global Health Institute. I came back and was waiting for him. I said, we need equipment. And I heard there was a surplus store. And at the surplus store might be some equipment. They sell it. So it turns out, what did Duke do? If you had a ventilator that costs, anesthesia machine that costs $40,000, and then you depreciate it over 5 years, you get a new toy. Well, what happens is that anesthesia machine was working fine the day before it left the OR. Well, it goes to the surplus store. And in the surplus store, a liquidator buys that anesthesia machine for $600. And the next morning, it's on an internet site for $6,000 to be sold to veterinary clinics in the US or to third world countries to buy it for their use. So we said, what happens if we kept that stuff? And so I started this program with the help of Dr. Zhao and Dr. Mercer and Jane Pleasance, who does procurement, called Duke Global Health Plus, and it's replacement of life-saving use surplus. One little aside, just to those of you who've been at Duke for a long time, you know how things work around here with the risk aversion, maybe would be the right word. I came up with the name, and the name really was placement of life-saving use surplus, and I got a call from a lawyer saying you can't use that as your acronym. And I said, well, why can't I use that? They said, well, is it really all life-saving? We have a problem with that L. And I go, seriously? Okay, how about life-giving? Can we use that? And literally what I hear on the phone is life-giving okay? That means there's 2 lawyers in the room on this phone call. And then they said, well, we don't like the word used because it sounds bad. It sounds like we're dumping equipment. By now I'm on my computer typing in, my thesaurus used, and I came up with the term, usable. So now it's life-giving, usable surplus. So we kept the plus, and we're able to continue. The other T I'm going to talk about is twinning. A lot of surgeons go to a country and they do a bunch of surgeries, and they may train a few people how to do some techniques, but they don't raise the boat of everybody. So our idea was to raise everybody's boat. We were going to take anesthesiologists, OR nurses, ICU nurses, recovery room nurses, biomed engineers, physical therapists. We're going to take a whole team and do that. And the third T is training, and I'll talk about that. And the fourth T is this top-down approach, which I'll talk about also. So what happens when I get back? Now, I'm very motivated. If you're a surgeon at Duke, literally every time you go to the scrub sink, even this morning, to scrub my hands to get ready for the surgery, there's some rep out there wanting you to try their new thing or do their new toy or something. Well, now the tables are turned. I was like a bloodhound now chasing people down. So the reps were running from me now rather than me from them. And so in 11 days, I got our first piece of equipment, a ConMed bipolar, so we could stop bleeding on the brain. I call this dumpster diving because now I wanted to go see the surplus store. There must be some stuff in there that's good. So I go into this thing. It looks like something like Raiders out of the Lost Ark, where they put the Ark of the Covenant after it killed everybody. They slid it into that little box in the corner. It looked kind of like that. And in one afternoon, I picked up more monitoring equipment, O2 sat monitors, Dynamaps to measure blood pressure, than they had in the whole hospital at Mulago. And any one of these would have saved that guy's life who was on the ventilator. I found my old talking bipolar. This is one I was just using in my room in OR 5 at that time. Turned it on and it worked fine. And then what you do now is now you're just hyper vigilant. You walk down the hall and you'd see brand new anesthesia machines in the hallway. You'd go, oh cool, we're getting a new anesthesia machine, that's great. Now you go, hey, where are the old ones going? And you talk to people, and then one night at about 8 o'clock, I saw all these new anesthesia machines in the hall in Duke North, and I said, what's happened to the old ones? They said, well, they're going to surplus, and I wasn't going to let those turkeys from the liquidators get them, so we wheeled all 14 of them, 385 pounds apiece, down to my lab in Duke South. Now, those of you who've been around Duke a long time, remember the PRT? Thank goodness there was still the PRT, and these just barely fit because it wheeled them all, took them down on a little trolley thing down to my lab. There's this thing in the Bible as a Christian, thou shalt not steal. Here's the problem. What do you need in Uganda? You don't need a monitor that when the humidity changes 3%, it goes black. You need something you can drop off a building and it still works. Well, the best thing in the world for monitoring things is these ProPack monitors. These are called transport monitors. We use them when we transport people from the OR up to the ICU or the ICU down to the MRI and back. And people who take patients on these frequently, when they get them up there, they forget them. So they're just sitting around on tables everywhere, just asking you, do you want to go to Uganda with me, please? Could you go? I would love to go to Uganda, but I resisted the urge to steal them because no one would know. And they called me finally. I bugged everybody so much. They called, Dr. Haglund, we have some. Do you want these ProPack monitors? And there was a pallet of 31 of them. We took all those. And then we collected more stuff. We got more monitors. You know, there's the ConMed Bible. My lab got filled up with all this stuff. And we bought them an operating microscope. And then basically in 4 months, we collected about 9 tons of equipment worth about $1.275 million. And then now we're going to take it over to Uganda. So we put it on a truck. Now I know, I'm not that naive. We have to get it somewhere over the water. So how are we going to get it there? How are you going to ship 9 tons of equipment to Uganda? Huh? Boat. In a big thing, right? Has anybody seen the movie Captain Phillips? Right? Where he's the captain of the boat that gets, they get kidnapped by the Somali pirates. My friend from St. Louis, who's a neurosurgeon, got his hospital to donate a CT scanner. It went to Miami, got put on the boat, it's supposed to go around Africa to Mombasa, Kenya, and it never arrived. And I don't know if the Somali pirates have this big round cool thing on the beach they don't know what to do with, but so we shipped it on British Airways. That sounded really safe. It was very expensive, but we shipped it all over there. And it went on all these crates, and we got it there, believe it or not. And here's Dr. Kirabawiri, one of the neurosurgeons, with his first operating microscope. He was very excited. We did our first camp in 2007. This is the Minister of Health, Dr. Malinga, who's, we're on about our 5th Minister of Health now. But my favorite part of this is actually, it's the thought that counts. It's not the Mulago Duke Neurosurgery camp. It's the Neurosurgical camp, that we had that year. So that was fine. And we brought a team of 33 people. This is the twinning part. Many of them still here. Dr. Zomarodi is still one of our faculty here. Senthel's still one of our best PAs here, and some of the nurses still go with us to this day. This is what the recovery room looked like before, and this is what it looks like after, a real recovery room. This is the ICU before, basically empty. Now it's got beds, and it's got all our ProPack monitors and everything we need to do proper ICU care. The biggest change was in the OR. Here's the OR before, and here's the OR now. Now they have drills, operating microscopes, suction, IV pumps, anesthesia machines, monitors, proper stuff to do neurosurgery. We did some simple stuff. This is Professor Apoki. He's the old general neurosurgeon that teaches all the medical students still. He doesn't operate anymore. He'd been on bed rest for 4 months with scars on his knees from a herniated disc in his back, and they didn't know what to do with it. And we took him to the OR, Dr. Kirabawiri and I, using their operating microscope, did a minimally invasive removal of his disc. And that thing right there hanging off the end, I'm sorry if you're eating lunch. We'll say it's just crab meat, but that's the disc. This giant disc, and the next morning he's up walking around for the first time in 4 months. The funny part of this story is if I do neurosurgery on you and I make a little tiny incision, when I'm done I close the skin with buried stitches and then put glue over it, I can still see that fine little red line. If I do neurosurgery on an African from Uganda and you close that up and you put clear glue on there, it looks like nothing happened at all. And I got done with surgery and all these people were gathered around him and talking in Ugandan really fast. And I said, Joel, what are they saying? They think you're a faith healer because they saw you do this whole thing. They saw you pull this thing out and now there's nothing there. And I said, no, don't tell them I'm not a faith healer. We did complicated stuff. This is one of my favorites because it was a big posterior cervical fusion with screws and rods. But the guy is he's a bridge engineer in Uganda, so he was fascinated by how we put this all together and the tensile strength of everything, and he did great. And this is what you see in Uganda when we go over twice a year. Giant brain tumors. This is a brain tumor coming out of his skull. It's as bigger than a softball, filling that whole half of his hemisphere. We spent 13 hours, 7 liters of blood loss, and after surgery he had a weak arm but was doing great and now had a normal-shaped head. This is what we're really shooting for. This is Dr. Zomarodi, one of our skull-based surgeons today. He's one of the best surgeons in the country. Here's him doing a pituitary tumor, and then at the end of the week, they're doing the pituitary tumor. So in the last decade, we finally looked this up. We've taken 472 volunteers over on 17 trips. Now, I'm 17 of those. And Dave Gleason, one of our nurse anesthetists, also has gone 17 times. We've done about almost 500 brain surgeries and basically given up about 34,000 hours of time to our work in Uganda. The technology transfer has been fairly impressive over the years. So our first year we took 9 tons, and now we've taken, I like saying it in Ugandan shillings, we've donated $45 billion worth of Ugandan shillings. It's really only like $13 million, but it sounds better in shillings. But we basically, every trip, we go twice a year, we take surplus equipment and supplies and restock things. But some of those ventilators we took over on the first trip, we took over 14 for 5 operating rooms, thinking, okay, then they can replace all 5 of them, and then when they go to replace them again, now they can start scavenging parts from the last 4, and there's still Narcomed 2B anesthesia machines working in the operating room at Mulago. We've been very well supported by the Chancellor and now Chancellor Washington. Richard Broadhead, when he was here, was very supportive, and Mike Mercer and my 2 division chairs have been very supportive. We get corporate support to do this kind of work. They give us equipment, used equipment. In the spine world, for example, you have the stuff everybody's using. You have your new cool stuff you're showing at the meeting, and then you have the 3rd generation stuff that nobody's buying anymore, and that stuff we get donated. And also, if I do a lot of surgeries for them, I think they should be interested in Uganda, and surprisingly they are interested in Uganda, which is great. So did we make an impact? Here's the number of surgeries they were doing each quarter before we came, and this is what it looked like the 2 years after. The gray bars are where we were there, so obviously more, but they did. It's kind of nice. You see this ramp up, and then there's this one drop off. Well, that's when a sewage line broke in the ceiling of the OR, and it was shut down for a few weeks. But basically, they ramped up to a significant number of cases. If you look at the complicated cases they do, like brain tumors, spinal cord tumors, spina bifida repairs, over 2 years, those increased dramatically, so we were building capacity when we weren't there. Using the OR. If you're an anesthesiologist and you just spent yesterday squeezing a bag for 10 hours while I did that big giant meningioma, and now I have another big giant meningioma on, I think my daughter has a dentist appointment today. Maybe I won't be able to do it. Maybe we cancel that case and maybe do it later. So they had a lot of days they didn't operate when they could have, and after we came, they're up to about 98%. One of the things that the twinning actually worked, we asked this question, which was kind of a cool way to ask it. If you did 1 neurosurgery case in your room, of the 100 days a year you have an operating room, they get 2 days a week. How often did you ever do a second case? Because if you do a second case, the anesthesiologist got to get a second patient ready, the nurses have to re-sterilize all the equipment, everybody has to work together as a team. The year after, almost 40 times they did more than 1 case, and sometimes they did 4 cases, which even here at Duke, if I do 4 cases, it's going to be dark 30 when I get done. And the next year, almost 70 times they did more than 1 case. So they had really built their efficiency into their system. Can I get some water? Does anybody have? Is there water out? There's some water out there. I don't cough into the microphone for the next 20 minutes. The top-down approach is to say, if you're going to build a surgery program, what are you going to do first? You're going to do C-sections and hernia repairs, and then maybe you're going to do a gallbladder, and then maybe someday you do a colon resection, and then maybe get up in the lung, and maybe someday you do a brain surgery. My idea was, if we could do safe brain surgery in Uganda, thanks so much. If we could do safe brain surgery in Uganda, then everybody around us should benefit. There should be a halo effect. So on these 2 y-axes, this is the number of admissions to Mulago Hospital per year, and at the same magnitude, this is the number of cases. So in black is the total admissions, about 130,000. In blue are the new admissions, and red is the number of surgeries they were doing, which is about 1,200 a year. Came back the first year, even though admissions were down, they had done, almost 16%, but they had done almost 1,400 cases, and we were pretty excited about that. But the year after that, they did 2,500 cases. I went to the professor he's a colorectal surgeon who's the head of the operating room, and I said, Professor, I don't get how you guys doubled the number of cases you're doing. He goes, oh, Michael, before you came, my anesthetist was a very unhappy fellow. He would run around up there squeezing the bag, and I do colon cancer surgery, and unlike you fancy Americans who have staplers to put the bowel back together, I have to sew each layer back together by myself. And I could tell, looking at the bowel, instead of being pink and healthy, it was turning blue. And even though I sewed it together well, 5 days later, because he didn't get enough oxygen, because they couldn't provide it, he said the bowel would dehiss and the patient would die, and that was the end. So I quit doing them. But after you brought your equipment, my anesthetist, he's a very happy fellow. He sits on his stool, he adjusts the dials, blue or red, green, whatever, and he says, now I do 2 cases a day. So that's how they really increase their capacity. The third T is the training program. I'm the program training director here at Duke. I'm in charge of the residency training program here of our 21 residents. But they had no training program. So in 2009, we started our first training program. And here was our first 2 neurosurgeons, Alex Muhindu and Oscar Obiga. They both graduated now and are doing neurosurgery in Uganda. And then we had our next cohort, and I'm very proud of this cohort. We had 5 more. They've all graduated now, and the one thing here cool is this is Julie Sikabanga. She's the first woman neurosurgeon in Uganda, so we trained her, and she's amazing. She's just a real workhorse and go-getter. She's actually worked hard enough now, and with our help, she's going to do a pediatric neurosurgery fellowship at the University of Toronto, so she'll probably be one of the best trained neurosurgeons in all of Uganda. One of the problems was they only had an operating room 2 days a week, and I wanted my residents to get more training, and a lot of cases were backing up. And the problem is, if there's 5 trauma cases up on the floor and 1 brain tumor, what are you going to do that day with your 1 OR day? You're going to do the 5 trauma cases, or 4 of them. And the brain tumor, they sit on the floor for weeks and weeks and weeks waiting to hopefully get their surgery. So I was sitting in the tea room one day, and I said, you know, this is kind of small, but get the sink out, cover up the windows, maybe we could turn this into an operating room. We did. So we raised some money, raised $40,000 and turned it out. When I told the executive director we're going to change it into an operating room, he was super excited. When I told the head nurse of the OR I was going to take away their tea room, the look on her face, I could have killed me. I said, and right before we do that, we're going to take that bigger room down at the end of the hall. We're going to put in a nice Coreg coffee machine and refrigerator, and we're going to build you a better tea room. So we built them a better tea room down the hall kind of thing. And this got national news and press, and the first case we did there was a very complicated aneurysm, and in 1 year they went from about 250 cases, which kind of leveled off after we got there. Now they did over 500 cases. And here's kind of my crown thing. This is a very complicated, big, large tumor. This is looking, there's their eyes. You're basically sliced off the front of their head looking in. This is a big brain tumor, and this is me sitting down at the end of the bed watching on the monitor while our first graduate, Alex Muhindu, is taking that whole thing out by himself, and he's doing a great job. Here's our vision for 2030. When we started in 2007, even 5-6 years later, there's still only 4 neurosurgeons in Kampala and the 1 neurosurgeon at the Cure Hospital in Mbale. Now we have 3 neurosurgeons in Mbarara, and the goal is over the next several years is to gradually increase this so they get to 50 neurosurgeons by 2030. Now the only problem is their population, if you flip a coin when you see somebody in Uganda, 50% of the population are pediatric patients because they're under 18 or under. Half the average age in Uganda is just around a little over 18. So they're very young and they're having lots of children. So we start out with a population of 30 million. Now, you know, basically 23 years later, we're going to be at 62 million. So that's 1 neurosurgeon for every 1.24 million. It's made a dent. We'll have capacity around the country, which will be good. People don't have to travel from way up here down to Kampala. But what we're going to do is we're going to train general surgeons. They'll come spend 6 months with our neurosurgeons, and they'll learn how to do a depressed skull fracture or a subdural, or they're good surgeons. They could close a spina bifida in the back on a small child, and then it'll look like this. And now we're going to have 350 people for 62 million, which will be about 1 to 170,000, which is similar to what they had in Morocco when we started. So it'll be, you know, the U.S. is 1 to 90,000. So that will be able to handle and change how things are done. And with the halo effect and that top-down approach, our kind of hope is that it changes how medicine and surgery is practiced in the whole country, not just for neurosurgery, but for everybody. Now, in his book, Scholarship Revisited, Ernest Boyer was tasked by Carnegie Mellon to go out around the country in 1990 and say, what does it mean to be a scholar? Okay? And he basically went around and he found these 4 things: discovery, integration, application, service, and teaching. What would we call that now? We call that in 2018 basic science research, translational research, global health, and teaching, still teaching. The problem, he pointed out, which is still true today a little bit, is that if you want to get promoted, you better be doing that. Things like global health and teaching at that point were not, now it's better, but 10 years in 1990 it was not better. So this didn't get much say in getting promoted. He said basically, okay, here's what you can do. Do this at first to get your tenure and get your professorship, and then you can do this stuff at the end of your career. Well, I don't agree with that. I think we can do it all. And so the question is, could you do this all? Well, in that light, I met with my new chairman, John Sampson, who's a very progressive guy, very smart. You know, he's only got like 4 degrees. He's got an MD, PhD, Master's of Health Science, and MBA. But he met with me and he said, you're doing basic science research on brain imaging, and you're doing this global health stuff. And I thought, yeah, I am. That's great. Thanks for recognizing that. And he goes, I want you to pick one and take it to the next level. Like, give up one of those 2 I'm doing. Well, my heart's always been to do the global health stuff, so I picked global health. And I came back to him, and this is my neurosurgery, this is my team in 2014. Myself, Tu Tran, who is a graduate student in the DGHI, and Tony Fuller, who was a med student and a graduate student in DGHI. It was us 2 against the world. I said to Dr. Sampson, I want to form the first ever division of global neurosurgery and neurology in the country that's focused on global neurosurgery research. And so we started, but he said, well, I'll support that, but you can't just do this service teaching thing. You got to do research and you got to publish. And I said, okay, well, what do I have to do? So we have to publish 5 papers a year. I go, okay, well, that's, and he's smart. He goes, I looked at your CV. You've only published 1 global health paper in the last 2 years. So if you want the money, you got to publish papers because we got to have this be academic. So in October 2014, this is our little group we had put together. Catherine Staten, who's an emergency medicine, who's a brilliant young emergency room medicine global health researcher, had a few graduate students. I had my 2 sets of graduate students, and we started our program. We had 14 people. We published 15 manuscripts in the first 16 months. And we grew a little bit. In October 2015, we had 21 people. 17, we had 60, and now we have 100 people in our group, including collaborations with Stanford and USC. So this thing's just exploded. We have 7 faculty, we have research assistants, we have lots of graduate students, neurosurgery residents from all over the country. I really give them credit. We have our meeting every Friday morning from 6:30 to 8 a.m. because that's when I'm free. You know, the poor graduate students drag their tails in, but the ones in LA, they get up at 3:30 in the morning, they're on Skype, you know, you can tell they're just waking up kind of thing, but they're there. Or sometimes maybe they just haven't gone to bed yet. But this is our group. And this is just an example of what our Google Doc looks like. I mean, so these are all our projects, and there's even more down below this. These are the papers we published in the last 6 months, and we have all these projects, and we spend time going over and presenting our results at our division meeting. It's been a great effort. With our camps, with our BASS students, we have 2 huge BASS grants in our program, one run by Tony Fuller and one run by Deb Koltai, who's a clinical neuropsychologist. We do our residency training. We do our team. This is our team that went to Mbrar in 2016. And what have we accomplished? Well, Tony and my first two graduate students, I said, you guys, one of my philosophies is go big or go home, obviously. All the equipment we brought, all the stuff we've done, I like the go big or go home philosophy. They said, well, Dr. Haglund, we want to do the largest burden of surgical disease study ever done in the world. I go, okay, that's good, I like that. I said, good. And then they said, oh, by the way, it's going to cost $75,000. I go, well, this is when we had no money. And I go, well, So I went to my chairman. I said, could I get $25,000 out of my clinical collections and put that toward this project? He said, yes. And then I'm going to be forgiven. So I've already asked for forgiveness, so I'm sure I'm forgiven. But I set up appointments with Dr. Sampson, my chairman, and Dr. Mercer, the head of the DGHI. And I went and told Dr. Sampson that you gave me approval to put my 25 in. Can you put 25 in? And Global Health's going to put 25 in too. I'm just hoping Mike Mercer was going to say yes later in the day. And he said, sure, if they're going to do it and you're going to do it, great, I'll do it. And then I went to Dr. Mercer and said, hey, Dr. Sampson's putting in 25. And by the end of the afternoon, I had $75,000. So they did this study where they went to 105 areas. They did this systematic survey, household survey around the whole country. They went to 2,300 households. They looked at 4,300 individuals, and they basically figured out what was the current burden of surgical disease in Uganda at that time. And it was about 10.6% of people needed a surgery right then. 7% were minor surgeries, draining abscesses, bad wounds, club feet. But about 3.6% were major surgeries that they needed. And this was the largest study ever done compared to all the other 3 that had been done in Nepal, Rwanda, and Sierra Leone. Then we took it the next step. We have some really talented people, João Viscasi and some collaborators with Brazil on geographical information systems. We mapped out where all the hospitals were locally in the whole country. And then basically, if you take all the hospitals and say, how far is it to go and where's the largest burden of surgical disease, the burdens were down in Mbarara, Kampala, and Gulu up in the north. But if you took out the hospitals, then Kampala is pretty well covered, but Gulu really needs help, and so does Mbarara. So we actually put our second neurosurgery site down in Mbarara based on this. Tony Fuller, one of the graduate students, he slept on the floor in this horrible medical records room for several months, going through every patient that had ever been operated on there, and basically showed, he called me up, this is like when you, unintended consequence, he calls me, Dr. Haglund, I go, yeah, he goes, I've gone through all 2,000, or how many ever, maybe it was 2,000 patients, I've got all their records, I got all the outcomes. I go, great, how's it look? He goes, well, thanks to us coming, mortality rate went up. I go, what? How could it go up? We brought equipment, well, it turns out when you look at these complicated brain tumors, what they used to do, and that guy with the big tumor coming out of his head, they would open up the skin and shave some of that off and close the skin, and he'd do great. They wouldn't spend 13 hours taking the whole tumor out. So there was this unintended consequences that the mortality rate actually went up. Now it's come back down, but it went up. The infection rate, at least, it went down during the time we were there. So we were able to do that. The Stanford group did this cool thing. How are we going to get good follow-up on all these patients when they come? There's only a few sites, and they come from all over the country. Well, having the address of their hut is not very helpful, but having their cell phone number is helpful. So they were able to show that they got a 60% follow-up, and for the 2 hospitals we operated on, this is where all the people came from, but they were able to basically find out and survey all those people and see if they got post-op care kind of thing, which was great. Another study we did, which was kind of cool, was one of our graduate students looked at the delays to care and how they managed that, and was there anything we could learn from that. Well, it turns out if you look at when they come in, when they get injured to when they get to the hospital, from when they get to the hospital to when they get seen by a neurosurgeon, from when they get seen by a neurosurgeon to when they get their CT scan, and when they get their CT scan to when they get surgery. Because the problem there is a lot of times patients have to pay for that CT scan. It's almost, $175, so it's like 6 months' salary for the average person there. So they have to go around to their family and see if they can collect $175. So sometimes there's a delay. Well, what they found was the following. If you take head injuries, severe head injuries, and you say interval to an injury to admission, how long did it take to get their reviewed? Pretty quick. How long did it take to get the CT? They got it pretty quick. And get the OR, they did it all pretty quick. Turns out the outcomes were no better. But the people that got hurt were these poor people in the moderate head injury who had worse outcomes because they were the people that got delayed almost like days, like this is 10 days or 5 days. They got delayed 5 days till they got their CT scan. That's a big problem. And when you look at the outcomes, you can see that in the moderate head injury, they got delayed a lot, whereas the severe got taken care of better, but they didn't do any, the severes all almost die anyway. You need to put some more of your resources into these moderates. And now one of our graduate students is doing machine learning on could you plug in their data into an algorithm that we're developing and testing out and say this guy needs a CT right now because he's going to need surgery, this person doesn't, you can delay on it. So we're working on that. One of our other medical students, Bobby Grammer, I love these people I work with. So Bobby Grammer, we need a way, he saw these people deteriorate in the casualty ward and in the ICU because they couldn't get another scan. Here at Duke, like somebody comes in with a head injury, they have a little bleed like this, and they're fine. I say, get another CT scan in 6 hours and get one in the morning. And it's like, it just happens. There it would be impossible. So there's this infrascanner, this infrared scanner you can use on the outside of the skull where you can see superficial lesions. And Bobby Grammer's been working with this, and this is how great I love about him. He basically stayed in the hospital at Duke for almost 30 days. He saw everybody that came in with a head injury that got a CT scan, over 500 CT scans. And he used the infrascanner to look at it, and it's pretty accurate. Its sensitivity is about 96%. So we're thinking in these low resource environments, we could just have an infrared scanner, which costs $5,000, but then after that, it's basically free. You could actually scan people, and if someone gets a little sleepier, is it because there's brain swelling or because the clot's gotten bigger? You can figure that out once you have your first CT scan. Another one of our graduate students, this is a really cool story. Jihad came to our group from Sudan. I get a lot of requests to have graduate students from the DGHI be in my program. And you're only supposed to get about 1. Well, I had gotten 2 already, and they asked me, 17 people applied to come to your group. Can you take 1 more? And I go, it was the last day, and I looked through the things, and I saw this person named Jihad from Sudan, and we have some friends who are missionaries in Sudan and Khartoum, and I thought, we'll just take this guy, sure. Well, when this guy showed up, it wasn't this guy, it was she. Jihad is a woman, and I just, bad implicit association bias on my part, because I didn't think of a woman coming out to be a neurosurgeon from Sudan. That just didn't fit in my worldview of how women get treated there. So she shows up and she's brilliant. She's smart. She's worked really hard. She actually now, with all her hard work and her graduate work, she actually got into the Duke Neurosurgery program. So she's one of our trainees now. So I would have given her 0.00000 chance of getting into one of the top 5 or 6 programs in the country, but she worked her tail off. And this is one of the studies she did. She looked at the cost of neurosurgery. So she did this. She worked with this Professor Sloan in economics, did micro-costing, looked at direct costs, indirect costs, all the different costs for surgery, saw what costs those actually added up to be, and found out the average neurosurgery procedure, unlike here, which probably costs $40,000, costs $542. Then she did it for each surgery. She broke it down. So like it was $291 to do a burr hole. It was $1,200 to do a brain tumor. Here it probably costs $80,000 to do a brain tumor. The cool thing was, when you look at cost per disability adjusted life years, and you have AIDS and you need antiretrovirals, it's very expensive because it's an ongoing cost. If you just have heart disease and you need to be on aspirin and a beta blocker, it's very expensive. But if you are doing a craniotomy for an epidural hematoma, it's more like the cost of what malaria bed nets are. So it's very cost effective to do neurosurgery. A craniotomy for a brain tumor is still very cheap. So she did this study, which was really neat, and that was great. So just to give you an example as I close, just to sort of show you like a week in the life of our camp. So we just got back a couple weeks ago. We were there. Basically, we leave on a Friday. We get there late Saturday night. Sunday all day, we screen about 100 patients to see if they need surgery and put them in order. And then we operate like crazy in 4 different operating rooms for 4.5 days. And you can see when we're doing a surgery, this is Dr. Grant. I mean, this is the amount of observers that are in there trying to watch us do the surgery. And there's a lot of teaching and training going on. This is Eddie Savaskin. He's one of our chief residents. You see, again, in Uganda, you see these little encephaloceles, which are outpouchings from the back of the skull in a little infant. Sometimes there's brain in there, sometimes there's not. The skull didn't form normally, nor did the covering membrane. But then you see stuff like this in Uganda, where this is a little kid, and this is the encephalocele, and this little kid comes in, and this is what they look like after once you remove that. So we can make a big impact. You see people like this with this kind of skull lesions on their head, giant brain tumors that are growing not only into the brain but out of the brain. And you can spend a long time working on them. And this we spent about 8 hours on, and Dr. Eddie and I did, and instead of looking like that, now it looks like that. Another person, this tumor, you just get a feel. This is the side of the head slicing through like this, looking in the side. So here's their nose and their eye. This tumor is gigantic. We spent about 12 hours taking that out. Very hard case. And the other thing was hard about it, every one of these little things, this is the tumor. Every one of these little things here, these are giant blood vessels feeding the tumor. So it's a very, going in. Here at Duke, we would embolize those. They'd put something in the groin and put a catheter up there and block off a lot of those blood vessels. So by the time you take the tumor out, it's kind of almost dead. This thing was very bloody. And here's probably the most rewarding one I'll finish with. This is a lady. She's I think she's 74, not 46, 74-year-old nun in an Anglican church. She had a history of neck pain. And the problem is this bone right here is supposed to be touching that bone, and that's what allows you to rotate your head. And she was this is what the spinal cord should look like, gray with white on either side, and right here it gets really tight. So her hands wouldn't work. She was in a wheelchair. She couldn't feel her legs. Again, this piece of bone right there is supposed to be touching right there so your head can rotate. We took her to the operating room and did a very complicated fusion from the neck all the way down into her spine. The day after surgery, she could put her thumbs up. The day after that, she was writing. And then I'll show you, I think it's here. Yeah, here, let me see if I can get this to work on my computer. So this is her on the left. She's 19
this.
Sorry, can you explain
At
again?
the end,
Explain again.
I have not written like this for a long time. And
write
I
it
now
again, let
see
us see.
that I call you Isaiah.
Starting to write for the first time. She hadn't written this scripture. She's writing out Isaiah 43:1.
Verse 1.
And the coolest thing was she and her sister are nuns, and they play worship at their church. The one sister plays the guitar, and my patient plays the keyboard. She hasn't been able to play
Let
keyboard
me add your name.
for over 2 years. And I think I might be able to play keyboards again. Her sister said, well, use my fingers as the keyboards. And so they're basically practicing, playing keyboard. Hands were just pulled up. The cool thing about this, our physical therapist recorded it, and she said, while they're singing in their room, it's a big board, she says, like, everybody in the ward started singing at the same time.
Audience again.
Let's see, I'm going to get it locked up. I shouldn't have done that. Let's see. Yeah, so our future directions are same 4 T's, twinning, technology, training, top down. We want to do now research and sustainability is really important. We've done that cost-benefit analysis. How are we going to make this thing sustainable when I'm done? What we've done is we've set up a 3rd hospital, which is an Anglican church hospital. And the deal is the surgeons, we know how much it costs. The surgeons are going to charge the patients $1,200. So now they don't have to fly to Kenya or go someplace else. So patients who can afford to pay, they're going to take $600 of that, put it into our fund, and $600 will pay them. So they'll make triple their normal salary. They'll go from $10,000 a year to $35,000 a year. But we'll have about $120,000 to pay all the resident salaries and do all that. So that's our next thing. And my final slide is, this is great. So Pastor Jackson Sinyanga, who comes to me and says in my church in Raleigh, I'm going to go to Uganda and do great things for God. His brother-in-law, 10 years later, shows up with this brain tumor. And it was very complicated one near his vessels. And 2 days after surgery, we rolled him out of the hospital. And so it kind of the full circle of, coming through the full circle with help. He got me to go there, and now we helped his brother-in-law. So I'll stop there and answer any questions. Thanks for your attention.
I actually have one, Dr. Haglund. I'm curious, as you train these new Ugandans to be surgeons to be neurosurgeons in Uganda, are you finding that any of them are leaving Uganda once you've given them the training?
Right. So, good example. That's a great question. So, one of the Ugandans early on, before we started our program, he came over to Midwestern neurosurgery program, did research there, and then he tried to apply in neurosurgery. He applied to Duke. There's, his scores, his publications. He just no way would he ever qualify, and I'm not the one that gets the final say. It's our whole department votes on who he takes, so there's no way he was getting in. But the place he worked actually gave him a residency slot. So he finished his residency, leading in the last 2 years before he finished his U.S. residency. He talked to me, he's going to go to Embarara, going to go to Embarara, going to go to Embarara. And then what happens is you get offered a faculty position in Embarara for $12,000 a year, or a mid-6-figure salary to go to some little town in the Midwest. And what do you choose? You're living in Iowa now, but you're making, 60 times more than you would have been making in Uganda. So our idea when we started this whole program is we would not train anybody here. They come over to Duke for 6 weeks and do an observership when they're done with their training there, but we will train them there. Like tomorrow morning, I think I have a meet. Every other week, I have a teaching conference with the Ugandan residents. We have a room over there, and we Skype and or Google Chat, and we talk. So the idea is to train them in their own country so they stay. The other thing is we give them a salary over and above, like double what they normally get, and then they're bonded to us for 4 years afterwards. So if we send them to Gulu, they need to go to Gulu. So that's the way we've tried to work that out. So I think bringing them here is not the right answer, even though they'd probably be better trained. In a way, when you look at the numbers, 77% of what they see over there is trauma. So they need to be good at trauma, because that's what they're going to see. They're not going to see, like Dr. Friedman here does 600 brain tumors a year or whatever. He does brain tumors 3 a day. Well, they're not going to do 3 a day brain tumors. So we want to train them where they're at, and that's kind of been our philosophy, so they don't get that brain drain and stay. Yes, sir.
First off, thanks for all the work you've done. Just amazing story. So my question is what you've done in Uganda replicable elsewhere in sub-Saharan Africa, or is this really just kind of a one-off example of just how great things can happen with visionary leaders and the right networks of people and institutions?
Right, so I think personally we've kind of set the template. I mean, we've made a lot of mistakes. No doubt, I didn't show all my mistakes here, hardly any, but there's been 2 steps, 3 steps forward, 2 steps back frequently, and we've figured that out. So I think what we've done is a template for anybody else. So if there was a neurosurgeon and a group interested at UNC Chapel Hill that wanted to go, and they do, they're going to Malawi, and they want to go to Malawi, using our sort of 4T approach, the technology, the twinning, the transfer of teaching. I think anybody that was passionate about this, that has a health system behind them, like I've been blessed to have here at Duke, could do this kind of thing. So I don't think it's not, yes, you have to have like the Duckworth grit, right? The passion, the perseverance, you have to have that. And you have to have your university behind you. Now the university stood behind us in a lot of things. Those 34,000 hours of work, it's funny how once in a while when administrative people get involved, things actually get better. So I'd cut little side deals with the ICU and the CRNA people in anesthesia that they could go, and since it was taking us 5 or 6 days of travel and work, that they could get 5 days back on their vacation, like paid time off. Well, then all of a sudden the administration got involved and said, no, you can't really do that. You have to have them accurately document their hours. I go, okay. So we accurately document their hours. They're working like 16 hours a day over there. So they go over there and work like dogs for a week, and they come back actually with more paid time off than when they left because they're not working 40, they're working like 70. So the university's been behind us. So I think if you have an administration, university behind you, and they're motivated to do this like Dr. Zhao and Dr. Mercer were, department chair like Dr. Freeman, Dr. Sampson that allow me to go, and just the whole health system getting behind it and getting a vision for it, then I think anybody could do, any health system could do this. Could I do a lot more here? Well, no, it keeps us pretty busy, although we are going to probably go to, hopefully, I don't want to say it too soon, but hopefully go into KCMC next fall and start a program there because we have so much Duke work being done at KCMC. And Catherine State and our ER physician attending who's there, she would love to have us come do neurosurgery there. Yes, ma'am.
So I saw from your graph that Sierra Leone is desperately in need of the same program. And so since you've now figured out all the mistakes you made, I mean, is there an opportunity and interest to expand, to go, just for example, Sierra Leone, which I know isn't the only country that needs it, but it was the one that was on your map that was like, yeah, oh my God, it was.
There is that opportunity, but unfortunately, God only put 168 hours in the week. And I'm using those really to their fullest while I'm a busy neurosurgeon here. Yes. So yeah, I mean, I think anybody that was passionate about stuff like that could do something. I'm hoping our training our residents who come with us, you know, for those trips, that when they go off to their academic institution, that they'll take advantage of that and they could work with us, kind of thing.
Hi, what you're doing is commendable. I'm from Kenya, and I used to work in a mission hospital. Mm-hmm. And we'd get donors who want to donate equipment, but they'll be stuck at the port in Mombasa because of import duty and other stuff. And we had to grease palms of government officials at some point to get them in. I was just wondering how you were able to navigate that process and get all that equipment to Uganda.
Yes, so the big thing was, so this is one thing we did right, the Haglund go big or go home philosophy. When you show up with 9 tons of medical equipment worth $1.25 million, you know what? It doesn't get stuck in customs because Minister of Health want to stand next to you with, like they did with all the equipment and show the great thing they're doing for their country, which is fine. I'm totally behind that. But by having that sort of gravitas when we first show up, we didn't show up with like one operating microscope. Have we gotten taxed before? Why pediatric endotracheal tubes are taxable, I don't know. But it cost me $2,340, you know, at customs to get those through, and I couldn't get the whole shipment through unless I got those through too. So once in a while we get stuck, but most of the time I have either the Minister of Health or his chief security officer on speed dial, and so I can find them on their farm or wherever they are on a Sunday to get our stuff out. So we've got it down pretty well with DHL and the customs and providing a list and documenting everything we're sending, and that usually gets us through customs. But we've made some big mistakes. One of the nurses, trying to be helpful because she's interested in OB/GYN, she threw in a bunch of linens. Well, linens are taxable, so we got in big trouble. One of the other nurses thought, well, we're going to re-sterilize the sutures anyway. It doesn't matter if they're outdated, which is true, but if somebody looks at your shipment and sees an outdated piece of equipment, that's past its expiration date, they go crazy because they've had some really big mistakes. I mean, Uganda had this thing where the president and everybody was there for this $2 million donation from Egypt of vaccines, and when they opened them up, they're all expired. So now it cost them $275,000 to dispose of all the expired vaccines. So we learn lessons we have to be careful of. So Kenya's in pretty good shape. They have some really good people there for neurosurgery, and they have a good private academic with Aga Khan Hospital where the surgeons can work in Aga Khan and make good money but still come work in the National Referral Hospital. In the Mission Hospital, there's a William Copeland from Mayo Clinic who's basically a real strong Christian, who's given his life to working over there. And so we're going to have some of our residents rotate with him over in Kenya. Yes, sir.
Thank you. I think it's wonderful work. I often talk to John Bartlett about issues of sustainability. I think in the general and the long term, we need to develop a business model for this type of work. Because it has, in the way in which you're doing it wonderfully, it has historical roots in missionary and colonialism in this context. Medicine has historically been linked with missionaries, yes. Western missionaries. So the challenge we Africans generally faced is moving forward. You have, as you see in Uganda, tremendous human mobility. Because the demographic change in Uganda has to do with Central Africa, has to do with Zaire, has to do with Rwanda, Burundi. So for sustainability, we may look at units beyond the nation state of Uganda in order to address the long-term problem. So I think developing a business model where Duke as an institution and staff can make money, invest in research, and local hosts also can make money in hosting this. I think that is something I talked to John Bartlett, and I told him because I attended a conference in Ethiopia. Mm-hmm. So and I think it was raised that most American institutions, they focus on Anglophone Africa to do investment in medicine. Yes. So I told John he should go to Senegal and to Sudan. So hopefully he'll be able to do it next year. So the second point I wanted to ask is, do you have numbers, statistics from North Africa beyond Morocco? Because Morocco is an outlier. You have a lot of European retirees moving to Morocco to set a business to cater to this European population. Yes. So that may not be representative of the realities of the region itself. So I wonder if you have something from Tunisia, Egypt, and... Well, Tunisia and Egypt are almost... The reason I use Morocco as the example is because it's the same size population as Uganda, but Egypt is very well supplied with neurosurgeons, and so is Tunisia and South Africa. Like I said, 486 of the 560 neurosurgeons in all the continent were in those 5 countries. So the other ones are similar in their numbers. As far as the business model, I totally agree with you. So that's why we're doing this thing at the Anglican Hospital. That's because I'm getting more gray hair and getting older, and I'm going to be retiring someday. Or worst case scenario, I get hit by a bus, walking back to the OR today. This thing's kind of done, because so much of this comes from my professorship gets dumped in there. The money the industry's given is all because of my relations with them. We have to have a sustainable model where they can do it themselves. And this Neurosurgery Society of Uganda that's running that Anglican hospital is kind of my little mini version of that would support all the resident salaries, all the research assistants, everything they're doing on the research side. And we're trying to build basically what we have here, a division of global neurosurgery and neurology, a similar group over in Uganda that works in collaboration with us but is kind of independent. And then the final thing you said, yes, it's Anglophone. I spent 10 years working in Ecuador.
it sucked that I couldn't pray with my patients. It was terrible that I couldn't talk to them. And since I'm a bad American because I only speak like one language, English, that being in an Anglophone, country make our work easier. Although we did some work in Rwanda. Rwanda, see, the other thing is if a country is very organized, like Rwanda is, it works way better. They only have 3 neurosurgeons there for 10 or 11 million people, but they're very well funded and they can get the proper equipment. And in Uganda, before we came back, we'd been gone for a year because of there was some stuff last year we couldn't go. People are dying on the table. I mean, your family member's on the table getting surgery, and you're running around to pharmacies at 2 in the morning trying to buy sutures because they don't have any in the hospital, and patients are dying on the table. If we waited till the government actually acted, we'd still be doing nothing over there. And now we've got 11 years of experience and made some impact, but we really need the government to finally, some Ministry of Health and Ministry of Finance actually have to put some money into the health system. One of our ideas is having this Neurosurgery Society of Uganda. They could raise money. They could get donations themselves as kind of an NGO there. And they could raise money through our Anglican Hospital project where they get paid for doing surgeries. So the vision is they would do one for pay in the morning and one for free in the afternoon. And that one for pay, they'd split half and half for themselves and for our projects, and that would fund it. So that's what we're kind of looking at.
Thank you, Dr. Haglund. I want to be respectful of your time, so we're a little over. Thank you, everyone, for coming out.